Welcome to TALRadio English. This is CXO Showtime with your host Akshay. There are several preventable diseases that continue to pose a significant threat to public health worldwide, and many of these issues are not being adequately taken care of. Addressing these preventable diseases requires a multifaceted approach that involves improving access to healthcare and preventive measures, promoting health education and awareness, and addressing social and economic inequalities that contribute to health disparities. Our guest today is a pioneer in taking this step forward with Project ECHO. Dr. Sanjeev Arora, an Indian-American physician, founder and director of Project ECHO, a global tele-mentoring nonprofit dedicated to disseminating knowledge in rural and under-resourced communities. Dr. Arora is also a distinguished professor and Regents Professor of Medicine, Director of the Office of Clinical Affairs, and Executive Vice Chair of Department of Internal Medicine at the University of New Mexico Health Sciences Center in Albuquerque, New Mexico, wherein Dr. Arora has developed and implemented hepatitis C disease management program. Dr. Arora, welcome to the show.
Nice to meet you, Akshay, and pleasure to be on your show.
As we begin, what is Project ECHO and how and when it started?
Project ECHO is a way to democratize the implementation of best practices in healthcare for underserved people all over the world. And so the real problem we are trying to address here is that the right knowledge doesn't exist at the right place at the right time. And when that doesn't happen, enormous human suffering occurs. To put that as an example, if a patient goes and sees their doctor for a disease where the doctor doesn't have the knowledge to treat the disease, to diagnose the disease, many serious consequences occur. First of all, no value is created on the visit for the patient. The time of the doctor is wasted. The patient's suffering is prolonged unnecessarily because the diagnosis didn't get made in a timely way. There is long delay to see specialists in the country. And as a result, what happens is that diseases are often diagnosed very late. And this can sometimes lead to the death of the patients. So, for example, in 2001, I saw a patient in my clinic, and she was a 43-year-old woman, and in a room with her was a 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? And she said, I have hepatitis C and I want treatment. So I said, how long have you had this disease? And she said, I've had it for 8 years. So I said, why did you not come earlier for treatment? And her response was that I had called your nurse and there was an 8-month wait to see you. And I had seen my primary care doctor and they did not know how to treat the disease. And I'm a single mother. I live 200 miles away. I would have to make 12 trips to come to see you, and I couldn't afford to do that, so I didn't come. So I said, why did you come today? And her response was that I'm having pain in my right upper side of my abdomen. And I did an ultrasound of her liver, and she had a liver cancer. And this liver cancer now was untreatable, and she passed away 6 months later. And I was asking myself, why did she die? And the answer was she died because the right knowledge didn't exist at the right place at the right time, and she didn't have the ability to get to the right knowledge. And I developed ECHO to solve this problem, to get access to best practice treatment to everyone, because we realized that 6 billion people in the world, that is 3/4 of the whole world, doesn't have the right knowledge at the right place at the right time, and enormous human suffering occurs as a result of that.
Right. Sad, but that's a reality that we are facing. Probably something that you shouldn't have faced. Probably you should have treated the woman earlier on. But I guess that has also risen forward to a very big cause that you have taken up, Dr. Arora. One of the ECHO's guiding principles is human connections. Can you elaborate on how this principle is incorporated into ECHO model?
Yeah, first of all, since your audience, I suspect, is a large number of people from India, this problem is particularly relevant for India, where in the cities like Mumbai and Delhi and Calcutta or Bangalore, there are a lot of experts, world-class experts. In fact, people from all over the world sometimes go there for treatment. But patients in rural areas of India cannot get the right treatment at the right time because the right knowledge doesn't exist, and unnecessary deaths and suffering occurs. And perhaps later I can tell you about what we're doing in India. But going back to that patient in New Mexico where I live, the problem I was facing was there were 28,000 patients with hepatitis C in New Mexico, and only 1,500 had been treated. So I was asking myself the question, how should I get everybody on treatment? And that's when I developed the ECHO model based on 4 key ideas. The first was I would use technology to leverage expertise. And what I mean by that is one-to-many video conferencing. And in 2003, when I launched ECHO, Zoom wasn't there. So we had to bootstrap a solution. But it was the same thing. And the psychiatrist, a pharmacist, and me, a gastroenterologist, we decided we would democratize our expertise. The second key idea was to share best practices. So I went around the state of New Mexico to rural areas here. And I talked to primary care doctors there and asked them if they would be willing to become experts in treating hepatitis C. And I gave them my protocol and some lectures on hepatitis C. And I set up 21 new treatment sites. But they told me that, look, this is too dangerous a treatment. This is chemotherapy. And we cannot do this because it consists of weekly injections and pills and with side effects. But the second principle still was sharing best practices. But it wasn't enough. So I asked myself, how did you become an expert in treating hepatitis C? That's where the human connection comes in. Akshay, that was the question you asked. When I did my fellowship in gastroenterology in Boston, I would see a patient present to my professor. I would see another one present to my professor. In addition, when I was presenting to my professor, there were other residents there. They would present cases. I would listen. And we call this idea case-based learning or guided practice and all teach, all learn. It's a human network. So I said, I was doing this during my training for 2 years. And after 2 years, they said, now you're a gastroenterologist. I said, aha, I'm going to use this kind of human network, which I did in person, but I would use technology and create new hepatitis C specialists in New Mexico without them having to travel for training, etc. So that's the third principle, case-based learning to manage problems of dynamic complexity. And the fourth principle was to use the internet to track outcomes. And in 2003, I started my first ECHO session where all 21 of these clinics would join on an interactive video network, very much like Zoom today, and one by one present patients of hepatitis C to us in the university. And in a 2-hour session, we would discuss about 8 patients without their names or anything. And 15 minutes, I'd give them a lecture. As I did this week after week after week, what I found was in 1 year, they became great experts. The wait in my clinic fell from 8 months to 2 weeks in about a year and a half. And over the next many years, we treated more than 10,000 patients. And as we started doing research on it, we realized that what was producing value here wasn't just the knowledge of hepatitis C, which was very important, but the real value was also being created because of the human network, where we were reducing their professional isolation, building communities of practice, improving their professional satisfaction. Their agency was going up, their self-efficacy was going up, and they would not have been able to solve these big problems on their own, but as a community of practice, they felt fully empowered to help their communities. And so that's where, that's the secret sauce of ECHO, is the human network and the guided practice and an all teach, all learn framework. where actually the experts also learn from the learners, because the learners bring the local circumstances, the culture. They also bring the resource constraints that these patients face. And together we create the best solutions for patients.
Right. How do you think we can make this work as a catalyst for practicing change and system transformation?
Two or three levels of it. The first step we did was, okay, it worked for hepatitis C, and we published in the leading medical journal in the world called the New England Journal of Medicine that these rural doctors could produce the same outcomes as university specialists could. This paper was a game changer. It was published in 2011, and immediately, within hours, I started getting calls from different parts of the world to replicate it. So we said, look, we want to help 1 billion people because by 2025, because the fact is 6 billion people don't have the care. We need to transform this system. So we started sharing the ECHO model with any academic center, any university, any government, any not-for-profit that wanted to deploy ECHO. We said we would give it to you for free as long as you were willing to help the world. We would give you 3 days of training on how to do it so that you can go and help yourself achieve your mission with speed, with scale, with high quality, and at much lower cost. So we first trained University of Washington, then the next in line was University of Chicago, then Harvard, and then many universities and not-for-profits around the world were trained. A big change occurred when ministries of health in other countries, starting with India, adopted the ECHO model. India adopted it first for their national TB program. Why? Because about 1,200 people were dying every single day of TB in India, even though the medicine was free, diagnostic tests were free, everything was provided by the government, but people in rural areas didn't know how to treat it. Then they used it for the cancer prevention program nationally. Then they started using it for the mental health program nationally. And as currently in Africa, 14 ministries of health adopted the ECHO model. So this, as you've probably gathered, it's a hub and spoke model, Akshay. And we have 980 hubs in the world. We have about 4,000 networks operating, the kind I described one to you for hepatitis C. And we have had 4.1 million learning attendances by healthcare professionals from 193 countries. So the model is rapidly spreading around the world. What does system change here mean? We would like every government in the world, in all 193 countries, adopt the ECHO model to help under-resourced patients, low-income patients, minorities, tackle racial inequalities, get best practice healthcare to the very front line where patients are living and experiencing life. The last part of system change I'll talk about is the idea that ECHO is really not inherently limited to healthcare. It is essentially a system change model to upskill a workforce. It is a tele-mentoring model. It's a capacity building model. And we have tested it in the field of education, where the learners are school teachers. And we can train them to be better math teachers or science teachers or in literacy. As I said, we have about 100 networks. And I see huge potential in India to expand ECHO for education. The reason for that is, once again, the same problem I was talking about in healthcare in India. You can live in Delhi or you can live in Hyderabad where you are, and you're going to get a good education because there are some amazing schools there. But if you live in rural India, there's a very strong possibility that there's no school teacher who has the full expertise and ability to help that student achieve their highest potential. This lack of a good teachers in rural areas has huge potential to slow down the progress of India economically, from a health perspective. But the opposite of that, which is how I like to think in a positive way, is if we could mentor all the school teachers to be better teachers, it can change India. It can change its economy for the future. It can change its healthcare. It can increase per capita income. It can improve livelihoods. Many, many potential outcomes of using a system change model like ECHO.
Right. And how are these learning solutions will enable organizations associated with you to achieve their mission with the speed, scalability, and high quality at a lower cost? That itself is a big challenge, right?
Each organization has a mission. It doesn't matter what you do. You have a purpose, why you exist. Okay. That's one fact. The second important fact is each organization spends money, resources, people to achieve that goal. And again, it doesn't matter what you do, you are doing this. Okay. Whatever you do, you're spending resources to achieve your mission. What we are saying is when we bring you our technology platform, which consists of software, which we call iEcho, which consists of the Zoom platform, which we give to you at no cost to you, and we give you the training at no cost, you'll be able to achieve your mission with less resources. That's one thing you can do. Or with the same level of resources that you're currently spending, you can get much bigger outcomes, better outcomes. So how does that happen? So if you are a capacity building organization, for example, and you're training people to do a certain thing, you're mentoring them, what happens is you often have to do what we call high dose, low frequency training. So you've got these learners all over the state, all over, let's say, Andhra Pradesh, okay? So what happens is these learners come all the way to Hyderabad, right? And then they learn and then they go back. But then they are supposed to apply on their own. Whereas ECHO is what we call a high frequency, low dose method of training, where they can stay in their local environment and apply this knowledge repeatedly under your guidance until they go from novice to expert. So let me give you some data. The United States government in the country of Kenya uses ECHO, but before ECHO, they had a mission to train doctors in Kenya on treating HIV effectively. So they would call all these doctors to Nairobi, the capital, train them, send them back, mentor them, etc. And it was costing them $826 per doctor trained. Now, using ECHO, it costs them $20 per doctor trained, and it's also more effective. So that's an example of how now they have all the rest of the money that's left. They can use it either to train more doctors or to get more medicines or any number of other things that they want to do. But because the model is highly efficient and more effective at the same time, it has been described as what is called a disruptive innovation. So in around 2008, ECHO won this global award for $5 million US for the most disruptive innovation in healthcare globally, because we were able to break the connection between cost and benefit. That is higher benefit for lower cost.
Right. Is there a feedback mechanism from the medical practitioners in terms of their learnings on the patients? Do they discuss about these concepts when they actually meet up over the Zoom sessions?
So there are two mechanisms. The first mechanism is that anytime a rural doctor speaks on echo, they're expressing a need. So every echo session is essentially a needs assessment going on, right? So it's a constantly learning network going on. Secondly, we have this iEcho platform that after every session, they provide feedback for improving. So there is a continuous learning loop attached to Echo where we receive feedback, we learn, and we improve. And constantly trying to meet on a weekly basis, trying to meet the needs of community rather than being a loudspeaker or a broadcast station. Be a broadcast station, but more importantly, be a listening station. So when you listen and then broadcast and listen again and broadcast, you have that feedback loop for improvement constantly on the system.
Right. And the overall project is all about the collaborative approach and collaborative approach, not just across within US, but all across the world. And when we talk about a collaborative approach across the globe, we're talking about different nations, different cultures, different climatic conditions, different scenarios in terms of the availability of the healthcare benefits are concerned to the patients. How did you face all these challenges, and what kind of a strategy was built up to tackle these challenges? I believe, like now, you must have seen different challenges when you were working in Ethiopia, right? You must have seen different challenges when you were working in Kenya. There must have been a different set of challenges altogether when you were involved in India than what you have seen in New Mexico, right? So, how diverse were these challenges, and how actually were you able to address these, and what model actually worked to help address these challenges?
That's a really, really important question. And I think it would be very arrogant to assume that something that works in the US will just work in India. Okay. It doesn't work like that. The culture is different. The resources are different. The economic constraints of individual patients is different. The medicines available are different. The technology available is different. The government structures are different. The rules are different. The politics is different. Everything is different. But there is one important thing in ECHO, that we don't go and train doctors in India, in rural India. We partner with LV Prasad Institute in Hyderabad, where you live. We give them our technology. We give them our training. They live in Hyderabad. They know the culture. We give them the platform, the methodology, the support they need to track their data, to improve eye care in the entire state of Andhra Pradesh. Similarly, in Bangalore, we partner with National Institute of Mental Health and Neurosciences. In Delhi, we partner with the National TB Program and the National Institute of Cancer Prevention. So who is doing the teaching? The local experts in India do the teaching. For cancer, our echoes in India, we partner with Tata Memorial Cancer Center. All the experts are there. They take the responsibility to train rural primary care doctors to prevent cancer. They train oncologists in the smaller cancer centers to treat cancer better. So you talked about Ethiopia. We enabled the Ethiopian Pediatric Society so that they could improve the lives of newborns in Ethiopia. So let me give you an example. What was happening was when a newborn is born, it is really important for the professional creating the delivery to wait for 60 seconds, at least 1 minute, before they clamp the cord. So the cord is connecting the mother to the baby, that has to be disconnected before the baby can become independent. But you must wait 1 minute. Why? Because in the 1 minute, that placenta, which is providing nutrition to the baby, contracts and pushes a massive amount of blood into the baby. This blood has food in it. It has red cells in it. If you clamp the cord too early, what happens is the baby is anemic. Its growth will be stunted in the future. Many believe that the brain development is less if you clamp the cord too early. So what the Ethiopian Pediatric Society found was that for the vast majority of newborns in the 8 leading hospitals in Ethiopia, the cord was being clamped too quickly. So enormous suffering. So they used ECHO to teach the teams in these 8 hospitals what are the best practices to wait for 1 minute, not be in a hurry to clamp it. Because there's a little chaos there at that time, because the baby has to cry, baby has to take its first breath. So you have to show restraint and you know how to do it correctly. After they taught these people, in less than a year, for 3,000 live births, the cord clamping rate, best practice for less than a minute, went up to 90%. So you can see who was the teacher here? Ethiopian experts. Who were the learners? Ethiopian doctors. What was the problem? It was an Ethiopian problem. Who was suffering? Ethiopian children. So what was our role? Our role was to teach them the ECHO model, to give them our software, give them our technology, and enabling them to achieve their mission with speed, scale, high quality, and lower cost, not bringing United States expertise necessarily. Now, in the beginning, when we are training them, our experts will help them adopt the model, but the long term, they are supporting themselves.
Absolutely. And one other thing that I'm getting more compelled to check with you is that in terms of the vaccine preventable diseases and all, right? And then we have been through this big reality of pandemic, right? For the coronavirus pandemic. And what I have also seen that there are a lot of mixed opinions that initially reverberated into the society, whether to take vaccine or not take vaccine. How was Project Eco influential in addressing these issues across multinational efforts?
Whenever you need a vaccine administered, there are 3 or 4 important factors, right? Maybe more, but let's just say, firstly, the vaccine should be available. Secondly, you must have the logistics so that you can get the vaccine correctly to the right place at the right time. Third, so you must train the workforce on administering the vaccine correctly. Fourth, you must have an individual that is willing to take the vaccine. And fifth, there should be a culture in that community that vaccine is effective, right? So I'll give you an example of 2 developed nations where everything else was available, the United States and New Zealand, okay? New Zealand developed a culture that tackling COVID-19 was a national problem, and they would work together as one team of people as a population to tackle this problem. And the vaccine acceptance rate and vaccination rate in New Zealand was 96%. United States, our rate was around 60% to 70%, some number like that, because we were not able to create that team approach, right? So ECHO has been used extensively around the world for starting with the logistics of vaccine by the World Health Organization. How do you get the vaccine to the right place? Training the workforce to do that, training the workforce to administer vaccine. But the most effective use of ECHO has been to overcome vaccine hesitancy. to spread best practices so that the counter argument to best practices, if you take the vaccine, you will get infected with HIV. If you take the vaccine, you will get autism. You will, any number of reasons why people don't want to take the vaccine. That's when, in a place like India, using ASHA workers, nurses, to have the discussion with patients. And we've used this kind of model all over the world to overcome vaccine hesitancy. So then managing vaccine side effects, you do need experts to do that, so the right conversations can be had. So in order for a community to go from low vaccination rates to high vaccination rates, there are many, many steps, and ECHO can play a very, very important role in all of these steps, starting from hesitancy to training to storage of vaccine, logistics of how to get to the vaccine to the right place without getting destroyed, developing policies for vaccination amongst policyholders, etc.
Yeah, I mean that's a lot of effort involved out there, and with so many challenges. What do you think are some of the key successes and impacts that Echo has achieved so far, and what are the future goals for the organization?
I think the key success factors right now for us is that we have 515 peer-reviewed publications in leading journals in the world demonstrating that ECHO is very effective, that in a cost-effective way, it can improve the human condition, especially in healthcare. I think that it is being widely adopted by ministries of health around the world as they are learning about ECHO. I think the challenges for us are the world is a very, very big place, and we want to change the world, and it requires resources for us. We have to raise the resources necessary to support our activities. We are largely supported by philanthropy because we give our support to all these countries for free. We help them. We give them our technology. And so this is a continuous challenge for us to raise the resources necessary to change the world. Our goals are first to use ECHO for healthcare to reach 1 billion people by 2025, and then use ECHO for many, many other sustainable development goals, which I will talk a little bit to you now. For example, one sustainable development goal is gender equity. That is to improve the lives of women throughout their lifespan. So what does it mean? In India, it means that a girl child should receive a good education. How do we do that? So that every school teacher in a rural area is better. Another sustained development goal is a good education for all. Another sustainable development goal is livelihoods, which requires workforce training and mentoring for people to have the skills necessary to make a good living. Another SDG is partnership for the goal. We also obviously do that, but climate action is very important. For example, we have an ECHO for health impact of climate change and how to mitigate that. Our natural habitats, we have an ECHO for bird conservation. So all of these are our other goals, but we essentially are saying, Akshay, that knowledge has a different physics than money. That if today I gave you half my money, I'll be left with only half. But if I share my knowledge with you and you share your knowledge with me, we are both richer for it. And we create new knowledge of how to help the world. So what we are really trying to say is democratization of expertise to help people implement best practices is a really good way for us to start if we want to make the world a better place. And it's very difficult to envision a world which will have peace and joy and prevent unnecessary wars if there is so much inequity, to prevent terrorism. And knowledge is a really good starting place to start producing more equity in the world.
Thank you for sharing those very, very valuable insights, Dr. Arora. One last question. How can individuals and organizations to get involved with ECO and become partners or participants in the program?
Multiple ways. One is, let's say you're living in India or in the US or anywhere, and you want to learn in a particular area. We have an ECHO going on for 70 different disease areas. You can join ECHO. There's no cost to it, and learn. And then with that increased knowledge and mentorship that you receive for free, go and help your community in that field. You can be a teacher to become a better teacher. You can become a nurse to become a better nurse. You can get qualified in a field of nursing like infection control. Second, let's say you're an expert and you're living in Delhi and you spend, or in Hyderabad, Akshay, next to you, and you have this expertise and you are spending most of your time seeing patients, making a living. But let's say for 10% of your time, you want to do seva if you're a Hindu. But I know in Hyderabad, there is a strong Muslim community. Let's say you want to do zakat, which is the serving equivalent of seva. You are a Christian, you want to do tithing of your time. You can start an eco project and really democratize your expertise. That is your giving back to the community. If you're an academic center, like Osmania Medical College has just becoming a hub in Hyderabad, then you can use ECHO for that, just like LV Prasad does that. If you're the government like Andhra Pradesh, they are our ECHO partner. You can use ECHO to achieve your missions and goals with speed, scale. If you are a philanthropist, you can contribute to us. You can make a contribution to ECHO, and you can say, I want this used for improving healthcare in India. We will accept that and we will use that to build ECHO projects in India. So there are so many different ways to contribute, all the way from philanthropy to experts, to organizations, to ministries, to not-for-profits. You are a not-for-profit. You are interested in education of girls. You can use the ECHO model to amplify your work. So those are the different ways I see the listeners to your program can get engaged. If you are a communication specialist, if you're an Akshay, you could disseminate this radio program and raise awareness for ECHO. If you're a journalist, you can write articles about ECHO. There are so many different ways to contribute here.
Absolutely. Very nicely put up, Dr. Arora. Pleased to have the conversation with you and very insightful guidelines that you have provided to us. It really tells out the kind of a depth of information, knowledge, and your involvement in the field. It is really, really very helpful for us and for our listeners as well. Thank you very much for joining us today.
Thank you, Akshay, and thank you for your time.
Thank
And
you.
thank you, Ben, for arranging this. Really grateful to you, and bye-bye.